It's really a privilege to be here with you today to talk about functional tricuspid regurgitation, because a lot of people in this room have actually contributed a lot to the evidence to treat it, and certainly help me and the group evolve in terms of our thought process. So what I'm going to do is share with you some of the background about functional tricuspid regurgitation, talk a little bit about our current evidence generated by our own group, and then finish up with some surgical tips for everybody. So these are my disclosures. I've been involved in the development of various repair products with different inventors, and I actually had the idea for the triad ring, which I'll show you later, and I still serve as the national co-PI of the Medtronic core valve trial. So this is the anatomy that I want you to remember, and that is that the fibrous skeleton of the heart tells you where dilatation happens. So the next time someone asks you, how does functional tricuspid regurgitation work, you're going to remember easily, because what you can see is that the fibrous skeleton of the heart isn't in continuity. So when you think about a mitral valve repair, where do we put our band if we're going to use a band? We put it posteriorly. Now look at the picture. See, the fibrous skeleton doesn't really have continuity posteriorly, so that's where the dilatation happens. In a tricuspid valve, it's different. You can see that the tricuspid valve, the septal portion of the valve, has continuity with the fibrous skeleton. It's the right ventricular free wall portion that doesn't. And so that's why the targets for remodeling of an annulus are different based on simple anatomy. And Carpenter's group was the first group to really document that when they looked at anatomic studies and showed where the predominant dilatation happened was along the posterior side of the tricuspid annulus. Again, that's the right ventricular free wall side, which is away from the fibrous skeleton. And like every anatomic study, this has been documented now with echocardiography, and this is Judy Hung's paper that looked at the 3D dimensional changes in functional tricuspid regurgitation and basically found exactly the same thing that Carpentier found, and that is that the majority, you can see where she's drawn these dotted lines, the majority of tricuspid dilatation happens along the free wall, midpoint of the anterior leaflet to midpoint of the septum and the coronary sinus. So that tells you, again, the RV free wall portion is what dilates in functional tricuspid regurgitation. So Brunwald was the first to look at what happens with functional tricuspid regurgitation after intervening on the left side. And for years, this title, you can see, really propagated in cardiac surgery, and that was you could be very conservative about treating functional tricuspid regurgitation when you treated left-sided valves. And basically what her evidence was for that was that she decided to look at individual patients and see what happened to the right side after fixing the left-sided valve, and basically showed that there was a reduction in systolic right ventricular pressures and in TR grades after treating left-sided valve disease. And this became a very prevalent sort of way to think about this. And a lot of us, I see Paul nodding, a lot of us trained in an era where unless you had severe TR, it was never treated. Interestingly enough, one of the groups that has now become more conservative actually led the field, if you will, in terms of raising whether we should be more aggressive treating tricuspid regurgitation, and that was data from the Mayo Clinic, where they started thinking about looking at their late outcomes for late surgery or outcomes for surgery after tricuspid valve regurgitation. And basically what they discovered is that this was a pretty risky thing to take on. Once patients developed severe TR, they had a very high mortality rate, and basically came up with this idea that liberal indications for tricuspid annuloplasty with even mild or moderate TR might be reasonable. That's 1984. So you don't come up with new ideas. You just revisit history and have more evidence or more things to talk or more things to learn from. So This next paper is the one that everybody on the back row needs to remember, and this is the paper from Jill Dreyfus. And this paper is very important because it was the first paper to really, I think, highlight a new concept in treatment of valve disease, and that was, should we treat geometry in addition to dysfunction? So if you think about it, we don't treat an aortic valve that the leaflets barely touch and there's only minimal AR. You have to have severe AR, moderate AR, concomitant surgery. But here was the first suggestion that an annulus might be dilated and the valve dysfunction might be only mild, but we should treat it. That's why this paper is important, and that's become increasingly important as a concept. So what Dreyfus did was he basically looked at two groups. One group he was going to treat and one group he wasn't. And the key is that he was trying to focus on people that didn't have moderate or severe TR. And I'll just show you the picture. This was basically what he wanted to look at was patients that had 70 millimeter dilatations. Remember, now we're talking about 40 or 45. This was 70 millimeters of dilatation without severe TR. And then he basically decided if patients had this giant dilatation, and again, you hardly would see that anymore because you really have to have long-standing heart failure to get there. And I remember being one of the discussants for this paper when it was presented and making the point that the largest Carpentier ring at the time was only about 42 millimeters. So this was double the size of the largest tricuspid ring. You never see a 38 ring used here anymore, and I'll show you why that is in a little while. But at any rate, this paper really suggested that the treatment of the disease, patients that had concomitant annuloplasty did better than patients that didn't. And this was the first suggestion of treating a valve orientation or geometry as opposed to a valve dysfunction. Again, there were a lot of flaws in this paper, particularly on the medical therapy side. It really, there wasn't a lot of data about how the patients were taken care of after a surgery, but nonetheless, this paper became an extremely important paper in terms of shaping future guidelines, and it's one that's really important. There have been other papers now that have sort of gotten into this, and you've heard the phrase, the tricuspid is the forgotten valve. That's absolutely not true. Their literature is full of papers about the tricuspid valve right now, and I just picked a handful of them to sort of highlight, but this was a paper from Dion's group and Jerome Back talking about dilatation to prevent right ventricular dilatation, and basically the number they were looking at was 45 millimeters. So, Dreyfus was at 70. Now they were moving down into the 40s and talking about treating dilatation in this first iteration of 45 versus not, and basically finding again that patients that had dilatation that was greater than 40 did better when they had concomitant repair versus control group. So they randomized to treatment and no treatment and basically said treating the disease was better. This was a paper that gave you a different view, and I'll teach you guys again, the residents, if you really want to read a paper, you've got to get all the information and think about it. So this was a paper published in JTCVS. It was looking at the Mayo series, 700 patients that had mitral valve repair, and they didn't do anything to the tricuspid valve. And then they wanted to look later on what happened, and I'll just read you the conclusion. Clinically silent, non-severe tricuspid regurgitation in patients with degenerative disease is unlikely to progress after mitral valve repair. Tricuspid valve is rarely necessary. So that was the data, and they basically, to support that, they showed this slide. And this was in the main paper, and they basically showed the black bars were people that had low grades of TR. The white bars were people that had grade 3 or TR moderate to severe TR, and they basically said that over time it was stable. It started out, and interestingly, after 3 to 5 years, it started to go up. That would have been a red light to me, but as you can see, the paper was actually written in a very positive way, suggesting that not treatment was a good thing. But that's the sort of data that you have to really try and get, and you sometimes can't get all the data. But remember, all these manuscripts have limitations to words, and editors often the reviewers ask for more information, and the information often ends up in appendices. And so this paper had an appendix. And here's the data. Here's the data that is more interesting, I think, from this is the data that's more interesting from the appendix. And basically, what you can see here, after 5 years, 29.4, almost 30% of patients had grade 3 TR. So 1/3 of the patients had developed moderate or greater TR by 5 years with a treatment, with a plan basically not to treat it. So I would have the complete opposite view for this, and in debates, this is always one of those smoking guns. It's so much fun to have that slide in your deck, because that's, I think, an indictment of being too conservative if 1/3 of your patients are going to have moderate or severe TR over time. This is another small series talking about, now we're at 40 millimeters as opposed to 45, looking at patients that had greater than 40, treatment or no treatment. And basically the same finding. Patients that got treated had less degrees of tricuspid regurgitation postoperatively. And the reason I just picked these is to show you sort of the progression of how we got to where we are in the guidelines. So this is how we got to where we are in the current iteration of guidelines. This was the data from this last paper I showed you, which was also important, and that was, look at the difference between functional, rheumatic, and degenerative TR. And what you can see is that means that these were the mitral categories, and that's why you see us being you'll never see us do a rheumatic repair and not explore the tricuspid, or in almost all cases of ischemic mitral regurgitation, we now look at the tricuspid, because these patients have even a higher tendency to develop issues afterwards. And then in degenerative, you can see we're a little bit more thoughtful. Almost those etiologies on the mitral side are enough to get me to want to do a repair today. So this talk isn't about the guidelines, but I'm just going to review them quickly with you and just remind everyone, these guidelines, they're very hard to get into the guidelines. Committees or groups of people, predominantly cardiologists, get together and they review literature. The literature gets ranked. The papers that are going to be reviewed get selected. These committees are very, or at least attempt is to have half of them have no biases, or they're not inventors. They don't have, balls in the game, and they basically look at all these outcomes and then come up with these thresholds for intervention. And I think in a different day we'll talk exactly how that all works, just based on our few minutes of discussion this morning. But what's happened now in the guidelines is they've come up with another concept which is very good, and that's stages of valvular heart disease. And you have sort of a possibility you can have it. B, you've now been identified, but it's not significant. C, you now have more advanced disease. D, you have severe disease, and then C, you can separate out into C you can separate out as asymptomatic. D is symptomatic. C has cases where the ventricle's good and the ventricle's bad. So they have this nice rhythm now that they can they can look at any valve disease. And again, down here is this indications for surgery, and as Steve said earlier, class 1, that's a good one. So for severe, that's an easy one. It can be class 1. And the guidelines vary a little bit, by the way, across the pond between Europe and America. That's why I said 1 and 2A sometimes can be gray. Asymptomatic patients is what we'll talk a little bit about, and then we'll get into this idea of pulmonary hypertension and dilatation as sort of a thing. But at any rate, here are the new guidelines for intervention for tricuspid regurgitation, and you can see that for left-sided valve surgery, basically, I'll show you two things. One is there's really agreement now between American and European guidelines. Usually, wherever I just find that wherever the paper was published, that level of evidence is considered a little bit higher. So typically European, if the original data that they're basing it on is in Europe, the United States respects it a little bit less, and vice versa. However, now it's been in the cellar long enough that both committees agree on what the level of evidence is. And this sort of walks you through functional TR, and you can see that dilatation alone can be a treatment, and pulmonary hypertension, and you'll see us ask often in the OR, what are the pulmonary pressures? Because if the pulmonary pressures are high, we're not that interested in anything else in terms of information. That's happened a couple of times this week. And you can see again why that is, because pulmonary hypertension is such a marker for progression of TR over time. And then the other side is easy. Whenever you're symptomatic, that's always going to be treated. And then the middle thing, this asymptomatic severe TR, which is not the topic today, but that's actually very interesting in terms of the functional patients, because those patients will do better with early surgery. That's a lot where that data that Mayo talked about very early on came from. So this editorial was written by Pat McCarthy last year, and I'll just show you the title of it, Evolving Approaches to Tricuspid Valve Repair, Moving to Europe. And what McCarthy was saying was we, the American side, was a little bit slow to get to the next level of evidence and start recommending aggressive treatment, primarily of tricuspid dilatation at the time of left-sided valve disease. So Europe was ahead of that, and again, I think one of the reasons was because Dreyfus's original paper was obviously, I think, weighted a little more heavily in Europe and the United States, but now they've caught up. And what Pat was writing about was this paper, which was presented by Joanna at the AATS last year and was published in JACC, a simultaneous publication. And this paper's generated a lot of discussion, and that's why I said when I think about our group, one of the things that's generated a lot of discussion is our work in tricuspid regurgitation, because you know we're very aggressive about treating it. We were really ahead of the curve. We started treating it very aggressively before the guidelines actually started talking about it. I think it's okay to do that, but if you do, you have an obligation to look at your patients. I mean, guidelines are just recommendations. If you go outside of them or you want to advance them, as I've always said upstairs, I don't mind if people do things very aggressively, but you should try and document what's happening. So that's what we did. We basically looked at 645 consecutive patients that had concomitant tricuspid repair or didn't. They had 645 consecutive mitral valve repairs. And then ask the question, how did we sort of get, what happened to them, the ones that got tricuspid repair versus not? And this was the algorithm that how we did it, and you guys are all familiar with it because you've been in the OR with us. But basically, if you have moderate or severe TR, you get a ring. So that's easy. Now you don't have, now you have mild, or you have no TR. You have mild TR. Almost everybody has mild TR by the time they have mitral surgery. Then we think about the annulus, and that's why you hear us always ask, what's the annular size? If it's over 40, that's always going to get a ring. Also, you notice if the right atrium's large and they say it's 38, we will look at the valve, because not all these rules aren't hard and fast. Occasionally you'll see 38 millimeters will mean something different depending on, in Ricardo, 38 millimeters is giant tricuspid dilatation. So, you have to, the Greg Fisher 38 millimeters, that's a tiny valve. So, you have to also think about what those dimensions mean. So that's why you'll see us open sometimes when we're on the border, just to look at the amount of tissue and do a saline, and we'll put saline in the ventricle. We always clamp the PA so we can do a saline test and we can look at it. And if we think there's a significant mismatch or that saline test isn't normal, we'll do a ring. And of course, atrial fibrillation, pulmonary hypertension, and low ejection fraction all weigh us toward tricuspid repair. All of that checks out no, then we leave it alone. And this week, I think we're batting 50-50. So again, we are very upfront about our biases. We're very aggressive toward repairing it. But if you have a normal valve, normal ventricle, no atrial fibrillation, you don't get a ring. So that's the population that I'm going to show you now that we studied. And basically, what you can see is 419 patients had concomitant tricuspid valve repair. 226 had an isolated mitral valve operation. And remember, the patients that had isolated mitral repair were really normal. They didn't have anything that made us worry about progression of disease, whereas the patients we treated, again, had pulmonary hypertension, atrial fibrillation, right ventricular dysfunction, more severe grades of TR, more severe grades of dilatation. These were sicker people. I mean, that's it just the way it worked out, because our screening was biased toward doing repair. So this was the freedom from moderate or greater TR at 5 years, and you can see that our concomitant group, which actually was the more risky group, actually performed very well compared to the control group that had no evidence of tricuspid regurgitation at the time of surgery. This was the longitudinal change in pulmonary artery systolic pressure. You can see preoperatively the group that got tricuspid repair had higher degrees of pulmonary hypertension. Over time, those two groups completely caught up. So the sicker group performed equally well to the healthy group by 3 to 5 years. And then right atrial area, same thing, much larger right atria in the group that we did concomitant tricuspid repair in versus isolated surgery. Again, no change over time. We caught up. The atrias were the same in both groups over time. This was the right ventricular dysfunction, same thing. Patients that had concomitant repair had a higher degree of right ventricular dysfunction preoperatively. Over time, same thing. The concomitant repair group actually looked exactly like patients that had normal right ventricles and normal tricuspid function to begin with, and that's just highlighted here, which was the catch-up of patients that had mitral and tricuspid regurgitation over time toward patients that had normal RV function to begin with. So it was pretty provocative evidence, I would say. It's a very large series, probably the largest one out there in terms of total patients. And the findings were consistent across the board. Again, these are not randomized trials, they're observational, which lowers the level of evidence. But I think a very significant paper, and I will tell you that it generated an enormous amount of discussion. So this paper was presented at the ATS. The first discussant was Tyrone David. And Tyrone, and there was such a vigorous discussion about this that we actually decided in the journal, the paper was published in JACC, we decided in the journal that we would publish many different editorial opinions about this paper because some of the discussants were all having a lot of fun, including myself. But at any rate, Tyrone basically said in his discussion that we don't know enough and that we need to learn more about which patients to do. And you'll hear the first paper at the ATS this year is he's gone back and looked at his group and degenerative versus rheumatic versus functional and have some more information about what his own sort of experience is depending on the group. His argument is that Barlow's disease has large tricuspid annuli and he rarely has to re-intervene. So again, he's not ready to commit that our data means anything. Craig Miller says, Dave, all that proves your group does very safe valve surgery. It doesn't really prove whether we should do it or not. Dion had a different idea. Robert Dion said, is the air in Toronto, Rochester, Cleveland different from that in London, Monaco, Leiden, Genk, Milan, and New York? And basically what you can see there, first of all, I would just want to tell everyone in this room, thank you, because the fact that all of you are here and work so hard puts us in that company, those are the best units in the world. So the fact that we're on that list is a real accomplishment. In terms of valvular heart disease, these are the top centers in the world. Toronto, Tyrone David, Rochester, Mayo, Cleveland Clinic. And then if you go the other way, that's London and Monaco, were both Dreyfus, Leiden, and Genk were Dion, Milan is Alfieri. You could add El Curry to that list, Brussels. There are lots of centers that are on the other side now being more aggressive. But at any rate, Dion wrote this really nice editorial, and I think it really validates for those of you that haven't seen Dion, he's really one of the icons in this field. He's a really respected guy who's just retired from clinical surgery, but he's sort of the father of the IMR literature in terms of doing ischemic mitral regurgitation. And you see his central message, and you'll also see this in our OR. When we operate on young, healthy, asymptomatic people with normal pulmonary pressures, invariably their tricuspid valve is normal. So he's saying we need to do earlier surgery. But the other thing that I learned, and I always said, when you do research, you always worry someone else is going to find it before you or they're going to publish right after you. But in medicine, it's good when the experts come out right after you and they agree with you. And you can see this is how Dion put it together in this article. TR 2R or greater, you see us do that. TR less than 2R, then grade 2. Tricuspid dilatation greater than 40, you see us do that. Then the 3.5 to 4, if you have AFib, rheumatic disease, pulmonary hypertension, right heart dysfunction, or just this visual of poor coaptation or LV dysfunction, that will also get you a ring. Now, I guess one of the reasons I'm so proud of that is because I think a lot of people in this room helped get the field to that. We didn't follow that. We've been leading that. But you can see this is a real, I think, sympathetic response and almost an identical way that we take care of patients today. There is a lot more new literature coming out. This was a meta-analysis looking at moderate functional tricuspid regurgitation. And in this meta-analysis, it was a bunch of papers looking at almost 2,500 papers. And basically, what it showed was most of these randomized series show benefit to tricuspid valve annuloplasty. And I'll just get to the punchline. And this was the reoperation rate. But this was the real overall effect. And this is what I tell patients in my office, that basically, repairing the tricuspid valve may not be necessary. A lot of patients will reverse a la what Brunwald, the data I showed you from Brunwald. But about 22-25% of patients will have an added benefit to tricuspid valve repair. I'll remind you that when you do a maze operation, you guys see us do maze for AFib, that data is about the same. If you just treat the mitral valve, about 50% of patients with AFib will convert to sinus rhythm. The maze gives you another 25 or 30%. It's not all or none. Just treating the mitral actually cures a lot of atrial fibrillation, just like treating left-sided valve disease will treat a lot of tricuspid regurgitation. But that impact, the treatment effect of that somewhere in the 20% range, and that's why you see us do it all the time. DeBonos' paper this year or last year also put a highlight on this idea if your ventricle's bad, if you're treating ischemic heart disease, to be aggressive. And basically what he showed was the progression and very poor outcome of patients that progress and develop significant TR over time. So very strong argument about treating that in patients that have ischemic heart disease or poor ventricular function. And this was Dion's paper published a few years ago. Again, we didn't know about this data when we were putting this paper together for Jack, but basically showing the same thing, and that was that patients that had moderate or severe TR that got treated had very favorable remodeling of the right ventricle early on. So a lot of data now talking about that. And the last paper I'll show you was from Philadelphia. Some of you will remember Andrew Goldstone. They looked at their data and basically had an identical sort of observation, and that was that patients that have grade 3, which is, again, you see at Mayo, they don't treat it. Their grade 3 patients did terribly. I think that should be off the table, frankly. And then the grade 1 to 2 patients, again, actually progressed pretty rapidly after 5 years. So again, same message, to try and be more aggressive. And I show this just because I like to poke at the Mayo guys when we're having these international debates. And that is that, who are all really good friends of mine, Rakesh Suri, and Rakesh is one of the guys that's sort of on the conservative side, but I pulled this up because you can see where, as I say, I try and convert one liberal every day. I also try and convert people about tricuspid valve repair. And now you can see the list from the Mayo where they don't like to do it. Now you see Rakesh saying rationally the performance of concomitant tricuspid repair at the time of degenerative repair should be considered for greater than moderate TR, right heart dysfunction, right heart failure symptoms, pulmonary hypertension, reduced LV systolic function, and organic tricuspid valve pathology. So slowly but surely, even the most arch conservative people are coming toward concomitant tricuspid valve repair, and that just summarizes some of the stuff that I've just shown you in terms of that. And just keep in mind these signs and symptoms. I think that when you're not sure, healthy people will be very conservative, and people that are starting to show concomitant signs of long-standing valve disease like pulmonary hypertension or atrial fibrillation or really hypertrophy, dilated right atria, these are people that probably spend a lot of time having TR, and we should fix them. Now, I'm just going to spend the last few minutes talking about repair. So this is the tricuspid valve anatomy that all of us know, and that is that we have 3 leaflets, an anterior, posterior, and septal leaflet. What's that triangle called, Bert? Yeah, so that's just the anatomy that helps us understand where the conduction system lives, because our conduction system basically crosses this commissure between the anterior leaflet and the septal leaflet and the tricuspid valve. So that's why you see us being very careful around this area with sutures, because that's an area that you can create conduction block if you damage. So there are 4 key principles of tricuspid valve repair: exposing the valve, preserving your leaflet mobility, stabilizing the annulus, and avoiding conduction injury, which we just talked about. So you've always watched the things I focus on the most is making sure we have good exposure to put our sutures in and that we're staying away from conduction, and I'll show you that on some videos. Now, there are three options for tricuspid valve repair. One is annular plication. You'll see us do that, and I'll show you an example of that, but that's basically using a suture to plicate the free wall. DeVega and Kay both described examples of that. The next is reduction annuloplasty. What a reduction annuloplasty means is you're using a flexible prosthesis to help you reduce the annular dimension. And then remodeling annuloplasty, which is of course a Carpentier philosophy, is fixing the valve in a systolic position. That's the most aggressive way that you can change the annular dimension. So the first example I'll show you is a variation of a DeVega repair. And what that means is that we're using a suture, usually with pledgets, and we're going to decrease or reduce the surface area of the annulus here. We're going to reduce the length of the annulus by plicating it, by tying the suture. And you can do this a variety of ways. We usually do it visually. People have described tying it over fingers of the barrel of a syringe. But basically, you're trying to bring the leaflets back together by reducing the annulus. Here's an example of us doing a DeVega in a young patient that has endocarditis. And you can see here is a good example of we'd like to avoid a prosthesis, and what we're going to do is we're going to use a pericardial pledgeted suture and reduce the free wall. You can see the clear annular dilatation here. And what we'll do now is we'll start at the midpoint of the anterior leaflet and then put horizontal mattress sutures as we come around the annulus with a Ethibond suture. And usually I'll take this around and come back up to the level of the coronary sinus on the septal side. And you can see as we start to increase the tension on this, it's going to plicate the free wall. So now we're bringing this around. The depth of the bite is the same as you're using for an annuloplasty. And now here's the other arm of this, and I usually just try and go between the sutures here, and as we apply tension, you can see the dimension of the valve changing. If the tissue's thin, we'll usually add a pledget in the midpoint of the posterior leaflet. Here, we're not going to. And now as we come around, you can see this plication effect. We'll tie that over another pledget. And I think when you see the saline, you can appreciate the effect of this plication on the annular dimension. Again, it's actually a very effective technique. It's used widely around the world because of the expensive rings, and I think when it's done in the right circumstance, it's a very valuable tool and one that we use. Now we know the tricuspid annulus, like all valve annuluses, are not planar. Imaging has shown us that we have a three-dimensional shape to our valve, and that's why when you look at prostheses, whether they're old or new, they have three-dimensional shapes. Here you can see a tricuspid, a classic tricuspid ring where you've got Carpentier's original rings were flat, and we used to bend them. He taught us to bend the ring to match the three dimension of the tricuspid valve, and of course when the first tricuspid ring was made by Edwards, called the MC3, invented by my friend Pat McCarthy, that had an automatic three-dimensional shape that respected the three-dimensional geometry of the tricuspid annulus. Now other rings, the new generation rings have come out. This is an example of the Medtronic Contour, which respects this three-dimensional shape. You see it's more open than the original MC3 or even the classic ring, and now Carpentier's Tricuspid Physio has a similar design and really is a third generation tricuspid ring that's very good for remodeling. When we measure try and pick a prosthesis size, there are different marks on tricuspid sizers. One are the septal marks. We use that as a secondary consideration. The primary consideration for sizing is taking the surface area of the posterior and anterior leaflet together and matching that to a sizer. So that's, again, the classic description that Carpente showed us how to size remodeling rings, and you can see here how one does that to pick a ring. And then before I show you a few videos of that, I just want to digress and show you this important paper from the Cleveland Clinic talking about durability. You know, there are lots of, it's shown you different thoughts about how to do tricuspid repair. Well, Cleveland was one of the first groups that went to look at their series of different techniques. And basically what they showed is when they used rigid rings or band annuloplasty, they had a better remodeling effect than when they used suture plication of some variety or another. Now, the other interesting thing about this paper is they were using smaller bands than they were using rigid rings. But that planted a seed with me, and one of the things I remembered, at the time it was almost all rings that were put in were over size 30, and this paper was the first paper to start talking about putting in smaller bands, and that did have an impact sort of on my thinking anyway, in terms of doing valve repair. The other important point of this paper was the role of permanent pacing wires, and we're much more thoughtful about pacing wires in patients that cross the tricuspid annulus, and it's not really the topic of today's talk, but suffice it to say, if a leaflet is entrapped, you're obligated to move the pacing wire, and even if it's not, oftentimes you'll want to put a suture to bury it in a commissure. So back to the story, this was Dr. Filsufi's paper. This is a very important paper from our group and one that I'm very proud of. We were asked to do the post-FDA study on the tricuspid valve to be used for approval in Japan. Japan requires some more information after FDA approval, and we were approached to do this study looking at the MC3 ring. In this paper, we started to enroll patients in this trial in 2002, and again, it was not very common then to use ring annuloplasties in small sizes, but we were sort of starting to be influenced now about the whole idea of functional disease and downsizing rings on the mitral side, and of course we were thinking about that on the tricuspid side as well. So in this study, basically this shows the data. The ring was very effective in terms of treating patients that had tricuspid regurgitation, and we had very good early results, and this went on to be used to help get approval in Japan. But one of the things that was very interesting in this paper was the observation of our ring size, and in the editorial that was written that looked at this, that discussed our paper, the authors made a specific point about our ring size. This paper, the predominant ring size was 26 or 28. It really was one of the first reports in the literature of using a remodeling ring in a small side, and that was something I think that Farzan and others that helped with this paper deserve a lot of credit for, because that now, as you guys are all used to seeing as downsized rings for functional disease, but at the beginning this was actually an observation that was made by the editorial, that this was one of the first descriptions of really using rings that were smaller than 30 in the tricuspid position consistently. And then was influenced by Dr. Moore's group, again, on lots of things, but in this particular paper, they were describing their dehiscence of rigid rings in the tricuspid position. Of course, the membranous septum, you have to be very careful about when you put those sutures in, and basically what they found is that the patients that were they basically were describing their own series where they found functional bands that they were implanting along the right ventricular free wall were as effective as rings and had a lower risk of dehiscence. So that's when I got interested in that, and for the next few years here, you saw us use a lot of bands. This was a description of that from Pat McCarthy and Toby Cosgrove, where you can see you're using a flexible band to placate the free wall, and now here's an example of that type of operation that we did for many years here, where we're going to put sutures in and use a upside down band to basically placate or change the dimension of the free wall of the tricuspid annulus here. So here you can see us putting our sutures in. We'll pass that through a ring. These were much more visual than they were honestly sized, but again, you're just trying to decrease the annular dimension along the free wall. You can stay way away from the conduction system. Your sutures can be placed up at the anterior commissural level, and there you can see us putting those sutures in. And that's what that looks like. So we did that for a long time, but I couldn't get away from my Carpante roots about remodeling with a rigid ring in a targeted fashion. And the next step was this. We started to take bands and we would run proline along the midpoint of the ring, trying to make that a little bit more rigid, thinking if that's the place that you may dilate, and since we're not coming across the septum, we at least want some rigidity along the posterior aspect of the annulus. And what that led to was this, which you guys are all familiar with now, which is the Medtronic triad ring. And basically in that ring, what I had hoped to do was to create a ring where you would have flexible remodeling. The tips would be flexible. So along the aortic valve, it could come forward. Along the membranous septum, it could go north and down toward the mitral or annulus and the fibrous curtain. But the free wall portion of the valve along the posterior anterior leaflet, as you can see, would be rigid. So where that green line is a rigid component to the ring. And here's an example of this ring being implanted. This is the one that you guys see most commonly implanted here. You can see this marked dilatation of the tricuspid annulus. And again, the advantage of this ring is because it's so open, you can stay far away from the conduction tissue. And again, you have this flexibility here. You can see us measuring the annular dimension over 4 centimeters. And to place that ring, we'll use Ethibond sutures, and usually you'll take a backhand across the top and bottom and forehand down the posterior leaflet. There's the sizer. You can see that's the plication you're going to get when you implant a ring like this. And so that's the reduction that you'll get when you implant a ring. You see how large this annulus was. Again, backhands across the septal portion, usually stopping at the level of the coronary sinus. Here you can see we're a bite in front of the anterior septal commissure, and then as we come around, we'll put these sutures through the annulus. We encourage crossover, as you know, in this group, and we'll respect that on the ring. But then as we come around, we'll then take this ring and we'll pass these sutures through both the flexible and rigid components, and that's what the final repair looks like. You can see just how open that ring is, and it still has a rigid component, so you've really done flexible remodeling. Now let me show you a remodeling ring as a strategy. This is a patient that's a reoperation. You can see this patient has tethering and dilatation. It's a relatively small valve. This is the type of valve that we would choose to put a complete remodeling ring in, so we want a completely rigid ring. There's the saline test. The leaflets barely come together. You can also see it's beating heart, and I'll talk about that in my last few slides. In our group now, for repeat tricuspid surgery, we almost always use beating heart. There's a physio tricuspid sizer. There you can see again the plication we're going to get with a rigid ring. And now you can see we're just measuring the anterior leaflet against it's a tethered valve, but I think we're going to not need any adjunct procedure here. As you can see, there's the 26 complete remodeling ring sizer. This is a tricuspid physio we're going to implant. And again, I don't do beating heart surgery in primary cases. In reoperations or patients that have severe TR and long-standing severe TR and worried about liver dysfunction, I tend to not clamp to protect the right ventricle and not put tapes around the cava to make sure that we're draining the lower inferior vena cava. And you can see we're sort of between sizes here. We're going to go with a 24 ring, re-emphasizing our own group's experience with small rings now. Now you can see the coaptation you can get with a remodeling ring. So again, we use all 3 of those techniques, remodeling rings, this triad sort of flexible remodeling, as well as plication. And then the last comment I'll make again is about reoperative strategy. Reoperative tricuspid surgery, it has historically had a very high mortality rate. We bring patients in, we do pre-optimization for several days. Our reoperations are designed to do minimal dissection. We usually don't see the aorta. Often these patients are femorally cannulated. We won't
put tapes on. We don't want to have any increased compression or pressure in the liver. And then you can see here the final test. And I like this slide because it shows you the three-dimensional aspect of functional remodeling, how the valve is coming up at the aortic valve level and down toward in the membranous septum, and there's you see the final result. So that's what I wanted to share with you today, and I really want to thank everybody in the room for your help in helping to lead, I think, the field in tricuspid valve repair. A lot of the staff and a lot of the people here have helped contribute to our knowledge in this space, and I thank you very much.